Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of videos in this compilation. This is of case one, which involves a patient with a blocked right ear. You may have seen an indentation in the centre of this wax plug, and that's where the patient had been poking inside their ears using a Q-tip. They actually attended with earwax in both ears. The left side, there was just a non-including wax at the entrance, so I scooped that out, hence why the correct, you can see there's a bit of debris on there. So these are single use, guys, so don't worry. I didn't bother showing you that left side because it was all but 30 or 40 seconds. I just mopped up near the entrance. I was on that side examining the ear. So here I've just using the right correct to try and elevate this wax, which is compressed against the canal wall. So you can see we've elevated it off the anterior wall, which is the front section to the right. And I'm just seeing if I can go underneath and lifting it high, but it seems like it's quite lodged beyond that. There is also some wax here, just past the first band on the left, but just trying to get underneath, and it was more spreading the wax as opposed to elevating it. So I think I'm going to revert to suction now. There we are. So I'm just using a Zollner suction probe. So a Zollner, you get different types of suction probes. You get a McGill suction probe, which has got a 3mm external diameter, so it's probably about 2.6 internal diameter. The Zollner, the external diameter is 2.1 with an internal diameter of 1.7 mil. Then you can get a Fraser suction probe. Now for the ear, typically the Zollner is used. Anything beyond that it's deemed too large to enter the ear. So for example, the McGill, which is the 3 mil, it leaves very little room inside the ear to manipulate and maneuver the wax, and also it's a lot noisier and a lot more powerful. So and I don't really think you'll need more than a Zollner suction probe to remove wax. I think if you have it too powerful, of course the noise levels increase. It can be uncomfortable for the patient in that perspective, but also you don't want to be having too much suction because you don't want to cause any trauma to the eardrum. So the eardrum itself is 0.1 millimeters in thickness, so 1/10 of a millimeter. Now, yes, it is fragile, but it's probably a bit sturdier than most people imagine, but it's still susceptible to trauma, whether it's barotrauma in this case, when I'm discussing suction, because that's pressure differential. The main body of the eardrum, the pars tensa, is you've got 3 arrangements of fibrous collagen connective tissue, and it forms a structure of a spider's web almost. You've got these concentric rings of fibrous tissue, fibrous collagen connective tissue, and then you've got these radially protruding fibrous connective tissue, all stemming from the centre of the eardrum. So we call that area the umbo. So it is quite sturdy, and you've got the parabid fibrous tissue, which are difficult to explain verbally what they look like, but they're more spirals. It's probably the best description I can give it. I did upload an image yesterday actually on my Facebook and Instagram page of the fibrous middle layer, hence why I'm talking about it a bit more today. So I'm creating a new Clearwax training guide with theoretical kind of components to it, discussing the outer ear, its anatomy, physiology, different pathologies of the ear, and of course the anatomy and physiology of the eardrum is vital to that. So again, if you follow me on Facebook, I'm putting a few images up that I'm creating as well for this manual. I uploaded one today. I've aptly named it the recipe of earwax. So if you guys, in fact, I'll put it at the end of this video. So let's see if you can. I'm sure you're all wax experts now, I think. You'll kind of get what I mean by the image when I say the recipe for earwax. It's not quite complete, but it's nearly there. So I will upload it at the end of this video for you guys. Now, if you stay tuned, guys, after this case 1, we've got patient 2, which is a follow-up to video number 1429. I will put the link in the description for you guys. And in that particular case, it's a very popular video, actually. It's almost hit 1 million views, and it's been only 2 months. It's of a procedure where I just removed layers and layers of dead skin keratin, and on the eardrum there was some granulation tissue. And so I was hoping that, given we had removed the wax, that granulation tissue will self-heal. I did advise the patient to use some acetic acid spray, and the patient attended, I think, on the 29th of November. They originally attended, I think, early November. So a couple of weeks after I saw them, and I examined the ear. So this is the patient now. You see the eardrum is clear. There's some dead skin already forming. So this has only been a couple of weeks. If you go back to the video, you'll see we've got all this keratin out, but it's in this region to the bottom right, so 4 or 5 o'clock. We call that the anterior inferior quadrant, and you've got this keratin building up, which doesn't bode well because it suggests there's some inflammation here. So when you've got inflammation of the skin, you go through what we call proliferation of the skin, so you get kind of a secretion of new tissue, and in this case epithelial skin, the outer layer of skin that lines the ear canal. So I know already there's some inflammation in this region because it's come back so quickly, but I can't see the granulation tissue. I can see something just north of the suction tip, but it's not very clear what it is at the moment. I just put some oil in because this skin is almost like shards of glass. It's really sharp edged. It's a bit uncomfortable for the patient initially, and it is attached. So I'm trying to almost glide it away. You can think about this like the kind of texture of it and the sharpness of it, just like some ice, for example. It's very brittle and sharp edged, almost like an icicle. It's got that very pointed, jagged edges to it. And of course we're on the eardrum trying to remove this. I'm just gliding away. This piece of skin looks like it's loosening. And once I remove this, there is some granulation tissue there. It's really visible actually on this occasion. It's more so than the original appointment. So then wrote to the GP. They got prescribed some steroid antibiotic spray. And then the patient did visit me in between Christmas and New Year's. I was trying to look for that video, guys. It's just a short video, and I know the patient in question is actually probably watching this. So I did airdrop that video to them. So if you are watching and if you got that clip, if you don't mind, could you mind emailing me that, because it is a very short video, so you should be able to, or even if you trim it down to less than 30 seconds, it should attach on an email. But the good news is that the granulation tissue is completely resolved. The reason why I was very keen to treat it, the patient was hesitant themselves. They were saying they couldn't feel it, it wasn't causing any problems, is it just best leaving it? And I said no, because when you've got granulation tissue, it means that there's some inflammation there. Granulation tissue is inflammatory cells, and it's a buildup of connective tissue, and it has its own vascular supply. So quite often granulation tissue, you can get a bit of bleeding as you rupture some of these blood vessels that are attached to the granulation, to the connective tissue. So some ENT would actually have cauterized this, so chemically cauterized it, so you're burning this, and you're hoping by burning it that when the rehealing process occurs, you don't have this formation of granulation tissue. And they use silver nitrite to help cauterize it. But because it's so marginal, it's on near the annulus. So the annulus is the white rim around the eardrum, almost between, say, 2 o'clock and 10 o'clock. And it's fibrocartilage. And in the first patient 1, I discussed the formation of the fibrous middle layer of the eardrum. And in fact, the annulus, you can see it there, the white rim, that's an extension of all the fibrous collagen connective tissue in the middle layer of the eardrum. We call that the lamina propria. And this fibrous tissue extends outwards to the periphery, and it forms the annulus, which is fibrocartilage. And what the annulus does, it helps to stretch the main body of the eardrum, the pars tensa. So the top part, the pars flaccida, where the eardrum is a lot more elastic. So the pars flaccida does also have all those fibrous connective tissue, but it's not in an arranged manner. It's more loosely dispersed, and it has more elastic collagen fibers, so it's more stretchy. It's not thinner. In fact, it's thicker than the main body of the eardrum, but it's a lot more elastic. But this annulus then extends outwards, and it's where the eardrum sits in the ear canal is a bone called a tympanic ring. And that's where the eardrum is housed, within that bone, that ring shape. And in that ring, there's a groove. And in that groove, this annulus sits in the groove. So it's made for the annulus. So it helps to stretch the eardrum, the main body, the pars tensa, and that keeps the pars tensa very taut, very drum-like. Because the pars flaccida doesn't have the annulus, it's not as taut as the pars tensa, so it's more elastic than the pars tensa. So you can begin to see that granulation tissue. And whenever you've got granulation tissue around the edge, you're always worried about a marginal perforation. For as I know, behind that granulation tissue, there's a perforation. There's a hole, and this is extending from the middle ear. So it is important that it is treated. I've just curled the end of the fine end. You can see that granulation tissue almost flopped there when I removed that skin. So yeah, it's all cleared now, guys. There's no more granulation tissue. I will try and share that video if I do manage to get it. But well, I hope you enjoyed that video and also the follow-up video, guys. Take care, keep well, and speak soon. Bye.